Dr. Torres, what determines how patients get listed for transplantation provided they meet the ISHLT criteria?
Tom, placing a patient in a waiting list is a very long process. The main goal is to make sure that it's safe for that patient to undergo lung transplantation. And obviously there are different reasons why patients may need a lung transplant. For example, if you have cystic fibrosis, we look at their lung functions primarily, how often they are being hospitalized, how sick are they when they get hospitalized, and how they recover. With patients with emphysema, we look at their lung functions, their quality of life as a marker of, is it time to move forward with lung transplantation? In patients who have lung fibrosis can accelerate very quickly. So following their lung functions, their quality of life tends to be our markers to see if they can move forward with lung transplantation. But then pulmonary hypertension is very unique because patients can stay fairly stable for a long period of time and then decompensate very quickly. In patients with pulmonary hypertension, our main concern is, are they going to bleed during the surgery? And how to manage that bleeding? Can they tolerate that type of process? Patients with pulmonary hypertension can decompensate so quickly that we need that other technology, ECMO, available for these patients. So we have all of that in the back of our mind when we are evaluating our patients to be placed in the waiting list. But once we meet the patient, then everything is, and we say, yeah, you need a lung transplant, everything is about safety. Is it safe to move forward with lung transplantation? And that's where we have the patients do so many testing. I feel bad for them because a lot of times that can take 2, 3, 4 days of testing after testing after testing. And we're healthy. We can go from one place to another place, walking easily. But these patients are sick, and it takes them half an hour to move from one part of the hospital to another one, to go from one office to the other one. So we do understand how challenging it is for our patients. We try to minimize the testing, but still, there are a lot of them. So we have to make sure that there is nothing abnormal in their lungs, that there is not a cancer. We need to make sure that their blood vessels are in the right place so that when the surgeons cut them, number one, they know where they are, and number two, they know that the connections that they're going to be making with the new lungs are there. We have to make sure that they don't have cancer in the abdomen, so we have to do CAT scans of the abdomen. We have to look at their kidneys to make sure that they are working well and that there's nothing structural that we can harm during a transplant. We're going to do a lot of blood testing, looking for infections like hepatitis, HIV, syphilis, infections that unless you look for them, you will not know that the patient have them until it's too late. We're going to make sure that the heart is doing well, that the patient doesn't have coronary artery disease, and suddenly we do a surgery and the surgery goes well, but the patient wakes up with a massive heart attack. That's why we do angiograms to look for blockages in the arteries of the heart. We also are going to make sure that the patients don't have structural damage in the arteries to the head. Imagine doing a transplant, the patient wakes up with a massive stroke. So we try to look for blockages. And if there are blockages, that doesn't mean we cannot do a transplant. It's just, let's fix those blockages, then reevaluate the patient and see if we can proceed with a transplant.
Dr. Torres, with regards to lung transplantation, are there specific contraindications?
Absolutely, Tom. So we tend to divide contraindications into relative contraindications and absolute contraindications, where the relative contraindications are some of illnesses, comorbidities that will make the transplant a challenge, but a lot of times, if we only have one relative contraindication or two, we probably will be able to move forward and help that patient. While an absolute contraindication having one of those, it just is a non-starter. We are going to harm the patient if we move forward with a lung transplant. So when we talk about a relative contraindication, we're talking about diabetes, hypertension, age, things that osteoporosis, things that are not so bad, but we know that the patient will struggle or may potentially struggle with a lung transplant. There are certain infections like mycobacterium infections that a lot of times we will be able to control the infection and kill the organism, but we know that a few times here and there, that bacteria will be very resistant and we will not be able to control it after the transplant. And that's why it's a relative contraindication. While absolute contraindications, having a solid organ malignancy like breast cancer, colon cancer, we have to wait 5 to 10 years of being cured of that disease. Melanomas, they are bad cancers and they're immunologically monitored. So you immunosuppress a patient and the patient may not have any evidence of melanoma, active melanoma anywhere. And then suddenly 6 months after the transplant, the melanoma is all over the place and the patients die. So we have to be conscious of some of these absolute contraindications, and that's where the work of our lung transplantations come in handy, because if we identify one of those absolute contraindications, then we will not move forward with a lung transplantation. Bone marrow failure, cirrhosis, kidney failure, all of them are going to make the transplant almost impossible.
So you say you feel badly for the patients, and I do as well. But I also feel badly for you. These must be very difficult discussions and decisions to have with them and their loved ones about what to do.
Absolutely. It's a challenge sometimes. And usually the challenge is more when you feel that, oh Lord, I want to help you, but I have found this test result that I cannot move forward. And if I move forward and I do a transplant, I'm going to hurt you. That's the type of conversation that hurts the most. Because as a physician, we are trained to help. And sometimes helping is not to do something. And as much as it hurts us, sometimes we have to say, no, this is not the right move and we do not support it. And that's a challenging conversation for sure.
Can feel it. Thank you, Dr. Torres.
Thank you, Tom.